So let's restart the session, and we are now about to discuss about infertility ultrasound. And if anybody wants to have a live interaction with me, they can raise the hand. And I will, we are having a technical team over here. They will unmute that candidate. So you have to raise the hand. The raise hand option is in the board. Now, in an infertile patient, what you have to see, you don't have to only see for a follicle only, but maybe that there is a fibroid. Maybe this fibroid is the cause of the infertility, and you are unnecessarily, focusing, spending more time onto your these follicles only. Maybe that there is an adenomyotic patch over here. Maybe this adenomyosis is the cause of your infertility. Dr. Priyanka has raised the hand. Let's unmute Dr. Priyanka. Dr. Priyanka, say hello. Hurry up, Dr. Priyanka. Accept the unmute invitation and say hello upon accepting it. Dr. Priyanka, say hello. I'm getting an intro. Okay, if there is any next candidate, please let me know. And meanwhile, if you will respond, I'll get connected. Now, maybe that there is a fibroid, maybe adenomyosis is the cause, maybe endometriosis is the cause, maybe that there is a polyp over here, which is the underlying cause, maybe that the void is the cause of the infertility, maybe the endometrium is very thick over here, and this thick endometrium, which is the endometrial hyperplasia, is the cause of your patients of having the infertility, and maybe that the PCOS is the underlying cause over here, and sometimes the PIDs also are the underlying causes of the infertility, and sometimes an endometritis can be also the cause of the infertility. Now, the point here is that when you are scanning a patient, infertile patient, you have to keep this checklist in your mind. Maybe that there is some abnormality in the uterus, which is the cause of the infertility, and you are unnecessarily spending more time, and the only time I will say on to the scanning of the follicle only. Now, the most common causes of the infertility, I will give you some sets over there. Maybe that there are some uterine causes, and these uterine causes can be congenital abnormalities of the uterus, infections, maybe some synechias are over there, maybe cervical stenosis is over there, maybe there is a reduced perfusion of the uterus, which can be seen on the color Doppler, which we will discuss in brief today. Now, this is from the uterus and from ovary. The causes from the ovary can be the follicular and the ovulatory abnormalities, maybe that there is the stromal vascularity problem, and endometritis can be the cause from the ovary and from the tubes. I can have infections or obstructions which can lead to the infertile patient, and from this there can be some cervical factors also. Now, only about a 5% of the total these infertile cases remains unexplained, and you will see in about 90-95% of the infertile patient some of these abnormalities, any of the abnormalities, I will say, which can be the cause of the infertility. So don't restrict on the follicle only. See what is the underlying cause. Now, when you are taking the folliculometry, there is something which is called the baseline scan, which has to be taken on the day 3rd of the cycle. What for? Because we have to see whether there is any, the cyst over there in ovary, which can be maybe that cyst is a functional cyst. And in baseline scan only, I can say whether I am dealing with a functional cyst, a dermoid, or something just abnormal. So take a baseline scan, and this baseline scan is usually taken, we are taking at day 3rd of the cervix. Now, the measurements, the correct measurements are very important. When you are taking an endometrium measurement is to be taken from one hyperechoic line transversely to another hyperechoic line, and the growth rate of this endometrium is 1 to 2 millimeters per day. Now, see, if it is 1 to 2 millimeters per day endometrium, that is why you are expecting about a 12 to 13, 14, I will say, 14 millimeters endometrium at day 12. Now, how the follicle is growing? Follicle is growing at a growth of 2 to 3 millimeters per day. That is why your follicle is almost double. Now see, 25 to 27 centimeters you will be having a follicle. Now see over here, the measurements are almost double. It is because the growth rate is double of the follicle from the endometrium. Now, you have to keep one eye onto the follicle, another eye onto the endometrium. What I mean by this is that equally important is the endometrium as is the follicle, because follicle is the seed. Just to give an example, follicle is the seed and the endometrium is the field where it has to get sowed over there. And if your field is not fertile, the seed will not sow over there. So have an equal understanding, and equal important is this endometrium. So that is what I am saying you, one eye here and another eye over there. Now, a dominant follicle will look like a dominant follicle only. We will not discuss that. The point here is that the dominant follicle, if seen, has to be correlated with the endometrium. If I am having a triple layered endometrium, try to understand, if I am having a triple layered endometrium, I should have a dominant follicle, and vice versa. If I am having a dominant follicle, I will expect a triple line endometrium. Why I am saying this? You all know this, but the point here is that if this is not an unruptured follicle, try to understand. If it is not an unruptured follicle, because sometimes a ruptured follicle will look like a dominant follicle. Well, if you are having a corpus luteum sometimes is having the same echogenicity as of the the follicle. Then you will not come to know. You will not make out whether you are dealing with a dominant follicle or a ruptured one. There, your endometrium will give you an idea where you are. If your endometrium is still triple layered, clear triple layered, then you are dealing with the dominant follicle. And if your endometrium is more hyperechoic, it means that you are in the luteal phase, and whatever here in the follicle looking like a dominant follicle is not a dominant follicle, but maybe a ruptured follicle or a corpus luteum, because corpus luteum sometimes is having the same look as of the dominant follicles. Now, sometimes you will see a small cyst-like structure in the follicle, and this is nothing but a cumulus oophorus over there. Cumulus oophorus, if seen, this is a very small structure, 1 to 2 millimeters only, and if seen, cumulus oophorus is a sign of a matured, dominant, mind my words, matured and dominant, plus 2 about to rupture follicle. So this cumulus oophorus, if seen, is the sign of about to rupture follicle, and not always it is seen, but if it is seen, we are now having a high-end machine, and if you are seeing a small cystic-like structure in the follicle, that is cumulus oophorus, and this follicle is about to rupture and rupture in one or a max of 2 days. Now, sometimes, if you are seeing some halo, now this is the halo over here. What is halo? Those who are having a basic understanding of ultrasound are knowing what is the halo. And if halo is seen, this is also a sign of about to rupture follicle. So if I am seeing a halo or crenation appearance of a follicle, crenation like this, crenation, that is also a sign of about to rupture follicle. And parallelly, I'm telling you, time and again, you have to keep an equal eye on to the endometrium, and endometrium should show you, some ill-defined triple layer endometrium, because this is now changing from secretory to the luteal phase over there, proliferative phase over there. So equally important is that correlation of what you are seeing from the ovary onto the endometrium. So now, if you see that your triple layer is becoming ill-defined, then also you are dealing with an upward or ruptured follicle. So these are the symptoms of signs of the about or ruptured follicle. And sometimes, many times, not sometimes, many a time, you are seeing a ruptured follicle, like a ruptured follicle only. But the point is, why I'm saying this, because sometimes the corpus luteum is also looking like a dominant follicle. There you get some clues, and there the clue is in endometrium. And if you are seeing a thick endometrium, a thick secretory endometrium, it means that you should expect a corpus luteum in the ovary, and this is all about. This is already a ruptured follicle. Now, if you are putting a color, on a matured follicle, a dominant follicle, you will see that the follicle is having vascularity, and if this vascularity is about a 70%, and more surrounding this follicle, that is also a sign of matured and about to rupture follicle. So corpus, so the color Doppler is also telling me that whether I am dealing with an about to rupture and a dominant first follicle. So this is that cumulus oophorus, which is very clearly seen over here, and it's seen is a sign of about to rupture follicle in a. So the point here is that the color Doppler is also giving me a clue of about to rupture follicle. Now the point here is that we are always concentrating on these follicles only, and we are missing our favorite this endometrium. Equal important is the endometrium. Now in endometrium, what first I have to see? I have to see for the vasculature. What I mean by the vasculature, let me set the slide first. Over here. Yeah. Now there is something which is called as the vascular zones. Now in this endometrium, in the first endometrium, when the uterus is a leg, I am seeing some, these vessels. Now see where the vessels are. Over here, I am marking over the vessels. Now where these vessels are? This is zone 1. So in zone 1, the vessels will be in myometrium. Oh, see, these are in myometrium, marked in red. Surrounding the endometrium. So they are in the myometrium, that is zone 1. First of all, try to understand these zones, then we will, this is the importance of these zones. In zone second, these vessels will be in hyperechoic endometrial edge. This is the over here. They are touching the hyperechoic edge over. This is the hyperechoic edge over here, which we previously discussed as the tunica functionalis. So they are touching this tunica. Basalis, not functionalis. They are touching this tunica basalis over there. So that is the zone second. And in zone third, what these will be? These will be in the endometrial inside the endometrium. Now see, internal endometrial hypoechoic zone. So why they are? They are in the tunica functionalis. So that is zone third. In zone four, these vessels will be touching the endometrial cavity. That is what I told you, the central canal over here. Now, these are the zones. Zone 1, zone 2, zone 3, and zone 4. Why we are discussing all this? Because if a blastocyst will drop over here, a fertilized ova, if a fertilized ova will drop in this endometrium, where I am having vasculature over here, try to understand. Will this be able to make a connection? No. They are far away. They will not be making a connection and it will easily get thrown out. But if the same blastocyst will drop into this endometrial cavity where I am having a zone 4 vascularity, it will get easily entrapped. It will get entrapped and it will get easily implanted. So this is the importance of knowing these zones. So if your follicle is growing, then rupturing, maybe that the vascular zones are very low. Like what I mean by low, maybe that your patient is having a zone 1. So this is the importance of knowing these zones. Now I am having something which is called as a biophysical score of the uterus. So this will be the last session now. Now see how important this ultrasound knowledge is for a gynecologist. Ultrasound knowledge is very, very important for a gynecologist because even if you are referring a patient to to a clinic or a hospital for this ultrasound, ultimately you have to take the final call what we have to do. And if you don't have any understanding, you will not be able to coordinate it. So biophysical score of the uterus, what actually here we are seeing for? You have heard of the biophysical score of fetus. I'm repeating, this is biophysical score of uterus. What we are here doing, we are seeing for something which we'll discuss. And then if that something is present or absent, accordingly, we are giving some points. Then we are summing up these points and then we are coming up with a biophysical score. It is same as we are doing the fetus. Now, first of all, what we are seeing over here is the endometrial thickness. Now, pay attention. Endometrial thickness is less than 7. The score is 0. And if endometrial thickness is in between 7 and 9, the score is increasing from 0 to 2. And if we are having an endometrial thickness of 10 to 14, then we are giving 3 points for that endometrium. But if endometrium is more than 14, then score is dropping. Try to understand. Then score is dropping. The point here is that with an increase in the endometrium, the score is dropping. The point is here. Don't get happy with a thick endometrium because thick endometrium is not a good endometrium. So this is how we are seeing onto this endometrium. Now the next is endometrial layering. Now see, I don't understand. Endometrial layering. Your triple line or a hazy triple line will give some points over here. And if I am not seeing any layering, then score is 0. But if the endometrial layering is hazy, then I am giving only 1 point. But if I am having a distinct trilaminar, I am giving 3 points for that endometrial layering. Next is the myometrial contractions. Myometrial contractions, we are seeing if I am seeing for the, whenever I am seeing for a semi-loop, Now, how to see that? That is a part and parcel of the course. We are right now taking a small CME over here. We are highlighting the important points, what you have to see, and not only see, what you have to actually study in ultrasound. That if I am having less contractions, now see, less than 3 contractions in 2 minutes, the score is 0. And if I am having 3 or more the contractions, then the score is 3. So next is the myometrial echogenicity. I am talking of echogenicity. If I am having coarse or heterogeneous echo I will be giving only 1 point. But if homogeneous, then score is 2. Next is the uterine artery Doppler. Now, each and every, not each and every, most of the machines are now having a color function also. And we are taking the uterine artery Dopplers in these machines. And the pulse type index, if greater than 3, the score is 0. Now, see, more than 3, the score is 0. And if the PI is in between 2 and 2.5 and 3, it is 1. But if PI is 2.2 to 2.5, then score is 2. It means whenever score is, PI is dropping, the score is increasing. So a dropping PI in the uterine artery is increasing the score. It means that what actually PI is. Now we have to go to the PI, what PI is. That will take a sufficient amount of time, maybe a 2 or 3 hours, which is covered in our color Doppler course. But for now, you remember that a drop in the PI is actually increasing the score. Okay, next. Now see, if it is less than 2.19, then the score is also increasing. Next, what we have to see is that very important, everything is important over here, but here we have to see for one of the important things, and that is the endometrial blood flow in zone 3rd. We have discussed this 5 minutes before, that if the blood flow in zone 3rd is absent, zone 3rd, recall what zone 3rd is. If it is absent, 0. And if it is present, where present in zone 3rd, then I can give 2 points. And if it is abundant, then the score is increasing from 2 to 5. And lastly, I have to see for the myometrial blood flow internal to the artery vessels, and if absent, 0, and if present, 2. What the point is? The point here is not to, I don't want you to have a calculator there and keep on adding all these points. No, the point here is that, first of all, your follicular study is not the study of the follicle only, but the study of the uterus also. And from uterus, the endometrium, very important. The first thing, don't get happy with the thick endometrium. More the thickness of the endometrium, lesser the score. See for at least this uterine artery Doppler, and a decrease in the pulsar index is increasing the score. At least see for the blood flow in zone 3rd. These are the important points. Try to get see for these contractions, and if there are more of contractions, the score will also increase. How to see for the score? There is a senior look. We will discuss it someday else. So the moral of the story is that I am having a very long study which is conducted. The moral of the story, this long story, is that if the score in that, now try to understand over here, we are concluding. If I was having a perfect score of 20, whenever I was having a perfect score of 20, it was associated with the conception of 100%. But when score was dropped just by 2 or 3, it means that 17 to 19 was having a conception of 80 only. 80 only. It means that even I am having a drop over here, even by 1, which is fitting here in 19, is dropping at 20% score of conception. Now, what is happening? If the score is in between 14 and 16, only 60% chances were here. It means that only half, roughly, only half of the patients will get conceived if the score is 14 to 16. And now, see what is happening. And if the score is 13 or less, how many resulted? No pregnancy. No pregnancy was reported when the score was 13 and less. What is your follicle? Your follicle is nowhere over here. Follicular study is incomplete without this biophysical score. So the point here is that, like I told you, you are having 2 eyes, 1 eye here, where here, onto the follicle, second eye onto the uterus. Equally important is the uterus. So this was all about this small digital CME. I hope that you have enjoyed this session. And in case you are having any question, you can post in the comment box. I will be having an eye onto the comment box. Anna, keep an eye onto the comment box. So there is a limitation of time in each and every CME. In past about 3 hours, we gave you an introduction of the topics. I will say this CME, each and every CME is actually an introduction of the topics which you have to understand. In CME, you will not understand the topic. You will come to know what you have to understand. So this knowledge is having no limit. And there is no age criteria for this knowledge. And if you are a gynecologist, then this ultrasound is your backbone. This ultrasound is replacing your stethoscope. Like without stethoscope, we cannot imagine or OPD. And now the trend is changing. Without knowledge of this ultrasound, we cannot make out a good diagnosis. And if you are a gynecologist, then it is very, very essential for you to have a basic understanding of the ultrasound. And ultrasound is not all about image only. You will make out an image if you are having a good understanding of theoretical understanding. And ultrasound is all about theory. 98%, if not 99%, is theory. People are doing ultrasound since 2 decades, since 2.5 decades, and they are struggling with these ultrasound diagnoses. Why? Because they are having a weak fundamental. Go to any institute. Have your basic understanding of this ultrasound, then you will do good with the final reports, with the final diagnosis, I should say. Now, see, I am getting many questions over there. Tell about the uterocervical length, POD fluid volume to indicate ovulation has occurred, sir. Next question, hypoechoic heterogeneous, please explain. Clear, thanks. Now, see, the point here is that I can take these questions. It is not that we will not take these questions. But the basic important point is that at this particular point of time, you will be having thousands, if not tens of thousands questions in your mind. Go through your books. But before that, have a get a basic training anywhere. So I will be taking these questions. POD fluid volume to indicate ovulation has occurred, sir. Now, the question is, I elaborate the question. The question is that what is the role of the POD fluid in case if I am having a ruptured follicle? The point here is that I told you that we should have a baseline scan. We should have a baseline scan. And in baseline scan, if I am having a baseline scan, and if in baseline scan, if I understand baseline scan, I don't have any POD fluid, then only the POD fluid, if seen at 12, 13, 14 days, will be an indicator of that I am having this fluid due to the rupture of the follicle. And if I am previously having a fluid over here, then if fluid present and increasing is a marker, is an indicator of the rupture of the this POD fluid. But not only this POD fluid. Now see, if I am having a POD fluid plus, and if I am having, if I am thinking on lines of a rupture of a follicle, what endometrium should show me? Endometrium hyperechogenicity will increase or decrease? Tell me in comment box right now. If this POD fluid is due to the rupture of the follicle, what the endometrial echogenicity will be over there? Will it increase, decrease, or remain same? In our comment boxes now, also keep an eye on the comment box. Repeating the question for the last time, because here lies the answer. If I am having a POD fluid, and if that POD fluid is due to the rupture of the follicle, what the endometrium status will be? I mean the echogenicity, will it increase, decrease, or remain same? Any comment? Decrease. No, it will increase. It has to increase. Because now we are having a thicker endometrium. We are now changing from the phase. But if it is same, then that POD fluid, if seen, is telling me, doctor, think tens of times before labeling this follicle as a ruptured follicle. So the point here is that you have to think this side, that side. One finding is not giving me any diagnosis, but multiple findings is concluding a diagnosis. That is what I am telling you time and again. Theory is the backbone of ultrasound. If you are having any more questions, you can post in the comment box. Show me the comment box. Give me fast. So, yeah. Now, please, not these types of questions that how much is the duration of your course and all these things. No. For that, we are having a team over here. Basic gynae ops course is for 3 months, advanced is for 6 months. We do have interactive sessions, we do have practical sessions, we do have simulators and all these things. So I am not in administration. We are having a counselors team over there. You can contact our counselors. They will give you details of each and everything. But in 2 lines, I will say that our courses are server-based. You can attend, you can complete our courses from the comfort of your home, and you can come to us for these practical sessions, hands-ons on simulators, on patients. We do have about 5 to 10 centers across the India for these practical sessions. But repeating for the last time, that practical sessions only will not do unless and until you don't have a grip on the theory. The practicals are based. So if you don't have any more questions, I will take leave from you. God bless all of you. Thank you very much. God bless.